Okay, so now we're done with the axial skeleton. Now I can move on to the appendicular skeleton. I'm going to try to cover as much. We'll probably cover the upper parts of the appendicular skeleton, hopefully to the pelvic girdle and below, but that's kind of a stretch goal for today. All right, so here we have. So what we have here is the shoulder girdle, or sometimes called the pectoral girdle. Either way, they're referring to the same part. So this is the pectoral or shoulder girdle, and what does it do? Well, it connects your upper limbs, aka your arms, your entire arms, to your axial skeleton. So remember, axial skeleton, skull, vertebral column, rib cage as well. But this is what actually connects the arms of your, or the bones of your arms to the actual axial skeleton. And then here we have the pelvic girdle. So remember, your axial skeleton is right here. So that's what attaches your lower limbs, aka your entire legs, to your axial skeleton. So this is why you call the appendicular skeleton. So the girdles and the upper and lower limb bones themselves, that's what you have when you refer to your appendicular skeleton. Okay. So this is another way to think of it. I learned it from the previous professor that it's kind of like clamps. So the girdle is kind of like clamps that attach your limbs to the axial skeleton. But the thing is that it's both the upper limb and lower limb, including those girdles. Those are your appendicular parts of your appendicular skeleton. So again, they're kind of like clamps that attach to that central axial skeleton. All right, so let's head off to Top Hat for our first Top Hat live question of the day. So a little review for you. What's the opposite anatomical direction from medial? Okay, let's see how everyone did. So most of you said lateral, and most of you are correct. Again, medial means toward the midline, lateral meaning away from midline. Next question. So what's the opposite anatomical direction from distal? Okay, let's see how everyone did. So most of you said proximal, and somebody spaced it out. That's still correct, but yes, proximal is the opposite of distal. And why do I bring that up? Well, not just for review, but this is going to come in real handy when we're talking about the appendicular skeleton, or actually just anatomy in general. Okay, so let's go back to our presentation. So yeah, remember that when you ever talk about proximal and distal, it doesn't necessarily mean refer to a midline. It's referring to some sort of central object. So again, I know it's like classic art, but it's Twitch. I'm being very cautious here. So again, distal, when you're pointing off into the distance, so you're going off into the distance, that's away from a central object, that's distal. And proximal, so when something's in close proximity, it's very close to you, right? It's very near. So it's kind of like saying distal is far and proximal means near. And then again, proximal and distal, these are opposite anatomical directions, just like up is opposite of down. Now, again, this is why I have to I'm very overabundance of caution on Twitch. Twitch is being a great host, I want to make them mad. All right, so lateral and medial. So again, medial referring to going toward the midline, and this guy again is standing in anatomical position. So again, medial, so like midline, like a median strip on a highway. That's in the middle, that's in the midline. So medial is toward the midline, whereas lateral, that's away from the midline. And you can go either left or right, it doesn't matter. As long as it's away from the midline, it's lateral. So you can go lateral into, I guess you would say cardinal directions or left and right. But either way, is it toward the midline? It's medial. If it's away from the midline, it's lateral. Again, so lateral and medial, these are opposites. And why do I bring that up? Well, now let's look at the shoulder girdle or the pectoral girdle. So what we have here is the sternum we just talked about, and but that's actually part of the axial skeleton. I'm just showing it for reference. So this part right here, the scapula, is part of the pectoral and shoulder girdle. And then again, medial toward the midline. And then you have lateral, that's away from the midline. So we're seeing is the right half, or actually we're seeing the right pectoral girdle. So this part right here, you probably might have known it as the collarbone. And what you can probably feel it right now. So this is your collarbone, or actually I'm touching my left one, I should be touching my right. But yeah, the right clavicle, your right collarbone. And then that forms the scapula, or common term, your shoulder blade. So the clavicle and scapula, they together form your pectoral girdle or the shoulder girdle. So what we have here is that this part right here, why did I bring up the sternum? That's part of the axial skeleton. So the clavicle is the part that actually attaches your pectoral girdle and your upper limb to the axial skeleton. So this is what we call the sternoclavicular or SC joint. And this is where you have the upper appendicular skeleton actually attaching to the axial skeleton. So this is why it's a very important joint, because what happens? Well, if this clavicle gets broken, that's going to cause this whole upper limb to be unstable, because again, this is what actually touches that to the axial skeleton. And what do you notice here? Again, this is why lateral medial becomes very important. Notice that, okay, here's the right clavicle, but is it completely symmetrical? Notice that the sternal end, again, the part that's more medial toward the middle, is different from the acromial end. This one's it's pretty blunt versus the acromial end. Notice that as you go here, there's a little kind of curve, and also this is curved as well. So the clavicle isn't completely symmetrical. It does have a medial side that's different from its lateral side. Now, clavicle versus ribs. So theoretically, if I just show you a clavicle, do not think it's a rib. Because why? Well, remember, the ribs are not only structural, but they also protect the internal organs of the thoracic cage. So they kind of wrap around. They're all generally very curved, except for those floating ribs. Well, they do have a slight curve. But in general, a typical rib has a curve to it. Now notice that clavicle has that rough kind of serpentine S shape right here as you go from medial to lateral. But here's rib 1. So often some people think that the clavicle is rib 1, but look at rib 1. Even though it's very, well, it's a lot, if you look at the rib 1 from the side, it's actually very flat and broad. But it doesn't have a S shape. It's actually curved because, again, it's kind of wrapping around this way. So rib 1 is just below the clavicle, but again, it doesn't have the same shape. Now, typical ribs 2 through 9. Again, I'm not going to do a picture where I just show you this picture and ask you, is it rib 4, 5, 6, 7? Again, I think that's unfair. But what we have here is that, look at the rib. It has this shallow curve. It's not S-shaped. So again, the clavicles are definitely shaped differently than the typical rib. All right, so we talked about the clavicle. That's what's the other part of the shoulder girdle? Again, your shoulder blade, your scapula. So here's your scapula in the back. Now here we have the anterior view. So say you got rid of the rib cage and you got rid of all the organs and muscles, and you were looking just at so this is the front view of a scapula. So you have all these markings are pretty distinguishable. I think they're pretty fair to test on. So this is on your slides. Don't worry about that. I like having to write this all down because I will walk you through the ones that I want you to definitely know. So yes, I do want you to know all these major landmarks on a scapula. And you're like, oh my God, there's so many things here. Don't worry, I'll walk you through it. Okay, so in the back, so that what we're seeing is like, okay, this was the front. This is looking at from the side. This is the right scapula. So if you're like looking at someone's right shoulder, this is what you would see from the side. And then now we have the back. And so the spine of the scapula is kind of like a book spine. It's a prominent ridge. And here we have the superior border, acromia, and medial border. Again, we're trying to orient ourselves, so you should be familiar with basically all the different views of the scapula. So like the anterior, posterior, and lateral view. Okay, so a little story time. So I think it was like, I forgot when this article came out, or maybe a few years ago, but on my way to Ireland, I was like, actually, it's really cool. I didn't know that we had Hawaiian crows, but they're extinct in the wild. So they were trying to reintroduce them. But when I went to Ireland, I was like, okay, I read this cool story about this girl who befriends like crows, and then they brought presents to them. So when I went to Ireland, I'm like, okay, I'm going to go to Ireland. I'm going to befriend the crows there and see what they give me. So I was hoping that like by the end of the trip, I would be like this, like best buds with some crow that's like my friend, and like I feed him treats, and then he gives me shiny things in return. So I went to Ireland, but did I make any crow friends? Well, not in the way I expected. My crow friends were a little interesting. So what do we have? We have a crow on me, but where specifically is this crow perched? He's perched on my acromion. So the acromion, you can feel it right here. I know, sorry for the pun, but this is the thing. If your crow perches on me, it's perched on my acromion. So the acromion is this point on your shoulder, so the highest point on your shoulder, and actually remember that acromial term referring, that anatomical landmark referring to the shoulder. So yes, that's where it comes from, that bony part of your scapula called the acromion. So the acromion is, again, what you see here, the highest part. This is the part where you're feeling your shoulder blade. You're probably feeling your acromion right now. And this is what it looks like from the back. So again, it's very, very prominent, and you can feel it. It's very bony, so you can feel it on your shoulder. And so here's our crow friend. He's chilled out. He's no longer packing. And then what's he has? So he's saying, hey, I'm not bringing you any gifts, but why? It's like, because you didn't call me by name. Oh, what's your name, Mr. Crow? My name is Glenn. And is this just a random name? Is this some random Irish name? No. So why is it called the crow's name Glenn? Because the crow sits on the acromion, and that's above the glenoid cavity, or sometimes called glenoid fossa. I know some professors don't like cavity because it sounds like a space, but when you hear glenoid cavity or glenoid fossa, just know it's referring to the same thing. So what it is remember a fossa is kind of some smooth surface. So this is actually where your upper arm bone, aka your humerus, that's where it actually articulates and fits into this glenoid cavity. So again, this is where your upper arm fits. So let's find out more about Glenn. Glenn has a favorite food. Glenn the crow has a favorite food. And what's his favorite food? His favorite food is apples. But the thing is that what's left after you eat an apple? Once you have an apple, you have leftover with the core. So when Glenn's done with his favorite food, now he's left the core. But why does he leave the core? Well, there's something in front of Glenn and in front of the crow that's called the coracoid process. So this other bony part right here. So remember, Glenn sits on the acromion, but when he's done with the lunch, he has a core in front of him. So this is what we would see if we're looking from the anterior. But if you look at the lateral side, remember, he's perched on the acromion, but anterior to the acromion, you have the coracoid process. So these are the two major bony parts you see here. The acromion is more posterior. The coracoid process is more anterior. All right, enough of the crow jokes and puns. Now let's talk about the acromion. So next to the acromion, you have something called the spine. Very important landmark because many things are derived or attached to that spine. And also many things are indirectly or directly named after that spine. So again, spine, at least in the scapula, is kind of like the spine of a book. I mean, spine in general refers to some sort of pointed object, but in the scapula, it's like a ridge. And it's kind of hard to, you can probably feel your own spine if you're flexible enough. But say you have like a significant other or friend. I mean, I know this is a crappy thing about teaching online. Like we used to have like if someone had their friend in class, you can actually feel someone's spine on their scapula by kind of feeling around that area. All right, so then you have the supraspinous fossa. So supra is another, it's kind of like superior, a different way of spelling it. So this fossa, again, a fossa is a shallow, smooth surface that's indented. So this is a shallow indentation that's above the spine of the scapula. Now, what's the opposite of superior? The opposite of superior is inferior, right? So inferior is another way of spelling it is infra. So now we have the infraspinous fossa. So this is the fossa that's below the spinal part of the scapula. All right, so we have, fossa, so supraspinous above the spine, infraspinous below the spine. Now let's flip it over so we're looking at the front of the shoulder blade again. So now we're looking at the anterior of the scapula, and now you have something called the subscapular fossa. Again, there's no spine in it. Again, the anterior of the scapula, there's no spine. The spine is in the posterior. So this fossa takes up this entire anterior, or almost the entire anterior surface of the scapula. And then, so why do I bring this up? So if you're planning on going to PT or any physical therapy, occupational therapy, or orthopedics, guarantee like a lot of the patients you have, we're going to cover joints later on, but common injury is a rotator cuff injury, and this is why it's important to know your rotator cuff muscles. So you have your supraspinous fossa. Again, we're looking at the back of the scapula right here, the back of the shoulder blade, and opposite of supra is infra, right? So or actually, let's rewind a bit. So here's the bone marking, the supraspinous fossa. So there's a muscle that attaches to this fossa. That muscle is called the the rotator cuff muscle that attaches to this fossa is called the supraspinatus. A little preview for muscle. We're not quite there yet, but just putting it in your mind. So supraspinous fossa, supraspinatus comes from that term. And then you have the infraspinous fossa. Hey, what do you think we should call that? If the muscle that attaches to the supraspinous fossa is called the supraspinatus, what should we call the muscle that attaches to the infraspinous fossa? Maybe let's call it the infraspinatus. Again, this is why it's sometimes important to know these markings because things kind of follow suit. And then you have the subscapular fossa. So in that same logic, if the supraspinous fossa attaches, or the supraspinatus attaches to the supraspinous fossa, if the infraspinatus attaches to the infraspinous fossa, what muscle do you think attaches to the subscapular fossa? Maybe we should call it the subscapularis. So again, now you know 3 of the rotator cuff muscles. And what's the last one? So there are 4 major rotator cuff muscles. Then you have the lateral border. Now, this is where the logic breaks down a little. So if it followed the same trend, we would say it's the lateral bordialis or lateralis. Not quite. It's actually, they throw a little curveball here. It's called the teres minor. So this is also why sometimes they call the group of muscles that attach to rotator cuff, they call it the sits muscle because of this. If they're using this mnemonic, this is why you often hear some PTs refer to it as a sits muscle. But notice, this is intentional. I made the teres minor lowercase. Why is that? There's a teres major and a teres minor. Common mistake that trips up a lot of people who are learning muscular anatomy. When they talk about the rotator cuff muscles, they say teres major. When you get to the muscles and rotator cuffs, I'll tell you why it's not a rotator cuff muscle. But yeah, whenever you use that SITS acronym, make it a point to use a lowercase because it's a teres minor, not the teres major. But again, if you don't get it, don't worry, we're definitely going to talk a lot about it, and you're definitely if you're going to physical therapy, you're going to hear, guaranteed, every day you're going to have some patient that has some sort of rotator cuff injury. Okay, so speaking of rotator cuff injuries, so can skeletal anatomy affect your risk of rotator cuff injury? Yeah, so as you see, this guy is not only has a lot of flexibility, he's also going to whip this ball at very fast speed. So what can affect that? Well, remember that rotator cuff involves the scapula, right? So this acromion right here, the highest point of your elbow, and remember your upper arm fits into this glenoid fossa. So there are 3 types. Actually, I read another ortho journal where there's 6 types, but let's just look at the 3 basic types of acromion. So we have type 1, type 2, and type 3. Oh, let's go back to top hat. So which of these acromial shapes do you think is the most prone to rotator cuff injury? And remember, you can click on the picture itself to zoom it in. All right, let's see what everyone's opinion is. And so it seems like people are divided between type 1 and type 3. So the interesting thing is that type 3 is more prone to rotator cuff injury. And why is that? So the reason why is that, prevalence, what we're talking about is how common is this in the general population? So as you can see, minority of people have flat versus this curve and this hook part. So it's all involving that acromion, but different shapes of the acromion. So a very flat one versus the most extreme and curved one, that's the hook type 3 one. So as you can see, most people have a curved or hooked type acromion. But the percent of rotator cuff tear cases, if the acromion shape didn't matter, you would pretty much see about the same numbers. But what do we see in real life? Well, notice that the flat, it barely has any of these rotator cuff tears, whereas people who have curved, they still have a higher risk than type 2, or type 2 has a higher risk than type 1. But notice that the hook type actually has the majority of the rotator cuff tear cases. So just by that little hook. So I think the theory is that because you've had that hook, it kind of grabs onto things when you were doing that extreme pitches or any sort of extreme motion in your shoulder blade, or actually in your glenohumeral joint. So the thing is that the hooked part, I think in one of the journals I linked, they suggested that sometimes if someone's prone to these tears and they're like an athlete, like that baseball pitcher we saw, sometimes they actually shave this part right here to make it less hooked and less prone to re-injury. But I should actually update whether to see if like that actually has better outcomes. But yeah, the hook, just by anatomy, just by a different acromion shape, that can predispose someone to more rotator cuff tear cases. That's why anatomy is very important, especially if you're going into physical therapy.